Hello, everyone, and welcome to an Introduction to Fracture Prevention Central, the Fracture Liaison Service Model of Post-Fracture Care Coordination, sponsored by the National Bone Health Alliance. You may submit your questions throughout the conference via the chat pod located in the lower left-hand corner of your screen. Simply type your question in the available box and click the Send Message button. Questions will be answered at the end of each presentation, as well as during the Q&A at the conclusion of both talks. It is now my pleasure to introduce your speakers, David B. Lee, MPA, Executive Director of the National Bone Health Alliance, and Richard M. Dell, MD, Lead Orthopedic Surgeon, Healthy Bones Program, Kaiser Permanente. Dr. Dell, can you please introduce David to the group?
Hi, this is Rick Dell. David Lee is the Chief Executive for the National Bone Health Alliance. I've worked with David for 2 years now. He is totally focused on getting us to the 2020 vision of 20% reduction in our expected hip and other fracture rate by the year 2020. So, David, take it from here.
Thanks so much, Dr. Dell, and really appreciate everyone's time today, and we're really pleased to be able to offer this first in a series of 6 webinars that we will host through the end of 2013. Really all around the Fracture Prevention Central tools, the Fracture Liaison Service model of post-fracture care coordination, and really our goal is to try, as Rick said, is to foster as many of these FLS programs as we can in the nation to get to our the National Bone Health Alliance 2020 vision to reduce fractures 20% by the year 2020. So before I launch into Fracture Prevention Central, just want to give you a little overview of the MBHA. So the MBHA was launched in late 2010. So the MBHA is co-convened by the National Osteoporosis Foundation and the American Society for Bone and Mineral Research. And really the whole goal of the MBHA is to figure out what are the big things in bone health that the community needs to do together as opposed to one sector or one individual organization doing. And certainly number one on that list is really trying to do what we can to foster the Fracture Liaison Service model of care coordination. So we currently have 54 organizational participants here at the MBHA. So we have 15 private sector members, 35 nonprofit and specialty societies, and we also have 4 government agency liaisons representing CDC, FDA, NASA, and NIH. So really our vision is to work together to enhance and improve the overall health and quality of all Americans by enhancing their bone health. Collectively, our membership can actually reach over 10 million consumers and over 100,000 healthcare professionals. So we've kind of built this large platform coalition to work together on very important things related to bone health. And then the other real central mission of the MBHA is to address the priorities through actually 2 different activities. First, the U.S. Surgeon General's report on osteoporosis that was released in 2004, and then there was a follow-on Bone Health Summit in 2008 that came up with the National Action Plan that laid out really the areas that MBHA is focused on: promoting bone health and preventing disease, improving diagnosis and treatment, and enhancing research, surveillance, and evaluation. So this next slide, just snapshot of the history of MBHA. So we've been, as I said, we've been around nearly 3 years now. It was launched in October of 2010 at the ASBMR annual meeting in Toronto. I joined the group in March of 2011. And it was that year that we established our 2020 vision, which was coined by Rick Dell, and we thank him very much for allowing us to spread the word. And I know that many other groups are now endorsing that concept as well. So really pleased that everyone's getting behind that 2020 vision. We did have a program at the Kaiser Center here in Washington, D.C., really highlighting the FLS model of care, the work Kaiser, Geisinger, the American Orthopedic Association, Own the Bone folks have done here in the U.S., as well as some of the other international efforts, as well as what the Veterans Administration is doing here in the States. And that was really our first chance to convene a group around the FLS as the National Bone Health Alliance. The next major initiative we launched our 2 Million Too Many Osteoporosis Awareness campaign in April of 2012, which is a campaign focused on both consumers and healthcare professionals, really talking about the 2 million bone breaks due to osteoporosis that happen every year and what folks can do about it to get screened and tested to improve and hopefully reduce the number of fractures that are happening due to osteoporosis. And then on the more scientific side, we released a bone turnover paper in July of last year and are now moving forward to execute that project into 2013. And then lastly, which is what I'll focus the rest of my talk on, is the launch about 2 months ago of Fracture Prevention Central, which is a resource center that really takes the tools that have been developed by the U.S. and international programs, as well as a mechanism to really help folks that want to get started in forming an FLS, or even folks that may be at a certain place in their development to continue to refine their program. So in the 2 months since we launched this right before the American Academy of Orthopedic Surgeons annual meeting because we had our Calf Mountain from 2 Million Too Many there, so we wanted to really make sure that we could highlight this new initiative to the folks attending that meeting as well. We've seen over 500 people that have registered to access Fracture Prevention Central, and I can tell you we had over 200 people that registered for today's webinar. So really pleased with the enthusiasm and interest in both Fracture Prevention Central and the MDHA. So this, once again, is just our overarching 2020 vision, as we said, reducing bone breaks 20% by the year 2020. I know in sitting down with Dr. Dell last month at the National Osteoporosis Foundation meeting, we kind of did a back-of-the-envelope calculation of, how many of these programs do we actually need in place by 2020 to really be able to hit, if not exceed, this vision. And we came up with about 1,000 programs. Currently in the U.S., we have somewhere around 150 to 200, 120 on the bone programs, as well as Kaiser, Geisinger, and other folks that are executing this model of care. So we certainly have a ways to go, and also because we know that it takes a number of years to really start bearing fruit on these projects, we probably need to have the additional 850 programs up in the next 3 to 4 years. So really looking forward to working with you on the phone and other folks to see what we can do to help you get there. So just at a high level, I want to talk about the FLS model of care. So it's a proven coordinated preventive care model which operates under the supervision of bone health specialists and collaborates with the patient's PCP. So really the idea is that post-fracture care is coordinated through what we call a fracture liaison service coordinator, which is a nurse or other allied healthcare professional who ensures that patients who fracture receive appropriate diagnosis, treatment, and support after that fracture. In addition, patients with recent fractures are tracked through a population registry, and there's a consistent group of processes and timelines established for patient assessment and follow-up. And certainly it's a very flexible model depending on who's really leading it, which major stakeholders are involved. But we've seen success over the last 15-plus years in both the closed and open settings. As I said, here in the U.S., the AOA owned the bone program, Geisinger and Kaiser. Internationally, in the U.K., Canada, Australia, New Zealand, lots of other places. So we have a lot of great evidence that not only does this improve patient outcomes, but it also helps reduce costs, which is something, of course, in this environment that is very important to be able to achieve. So very pleased to be able to help do what we can to foster this model of care. So just a little bit in terms of outcomes. So here in the U.S., Kaiser Permanente, since it launched its Healthy Bones program, which you'll hear a lot more about from Rick in a few minutes, since 1998, has actually reduced the expected hip fracture rate by 40%. And Kaiser estimates that if a similar program to the Healthy Bones model was implemented nationally, we could reduce the number of hip fractures by over 100,000 and save over $5 billion a year in healthcare costs. As another example, Geisinger, from 96 to the year 2000, achieved $7.8 million in cost savings through their FLS program. And the American Orthopedic Association Own the Bone program has achieved statistically significant changes in health professional behavior and referral. Currently has over 120 sites and 7,000 patients involved in Own the Bone from 31 states. And you know, as we'll talk about more later in this webinar, do want to really encourage folks to look at Own the Bone as the next step once they get started, because you know, there really is a lot of tools and resources there that will help you continue your journey to developing your FLS. So certainly something for you all to take a look at, and we'll be happy to connect you directly to the folks at Own the Bone to be able to talk to them about that potential as you move your program forward. So just a little bit on international outcomes of FLS programs. You know, many of these have been running for quite a while. So in Canada, they show for every 100 patients in a program like this, 3 fractures are prevented. They show healthcare cost savings of about $20,000 per patient over the patient's remaining lifetime for folks that are participating in such a program or through their institution. You can see the outcomes both in the UK and Scotland specifically, which is really, you know, the first group that moved this model forward. So, you know, very consistent data on elimination of fractures as well as cost savings. So, you know, we really see this as low-hanging fruit for folks to start pulling this together. So because of this and because of all the work that's been done both nationally and internationally, MBHA really came down on secondary fracture prevention as a central tenet of the projects and activities that we are moving forward. So among the things that we have been pursuing, you know, this is a very kind of multi-pronged approach, includes implementation of fracture prevention pilots and demonstrations. We also have a fracture liaison service reimbursement group here at the MBHA that is exploring the need for additional reimbursement codes, which of course is a central challenge in getting folks to understand, you know, the reimbursement landscape and how you can, at the very least, break even, if not make a little bit of money in running these programs. And then certainly providing tools, technical assistance, both to interested sites and health insurers through Fracture Prevention Central. We've also now talked to 8 health insurance companies to see if we can help them implement pilots or FLS programs in their setting. We also work with all the major national and international fracture prevention efforts. So the ASBMR International Task Force on Secondary Fracture Prevention, International Geriatric Fracture Society, the IOF Capture the Fracture Initiative, and the Fragility Fracture Network, among others. So really, MBHA, for instance, in the IOF Capture the Fracture Initiative is listed as the national toolkit, and they're helping us disseminate information about Fracture Prevention Central out to folks. So really pleased to see how this is moving forward, and just wanted to talk about a few of the reasons from our perspective that the FLS model of care has not been implemented as broadly as we would have liked. I think part of it certainly is lack of awareness among HCPs with patients who have fractured, you know, understanding, to get them to understand that those that have fractured are at highest risk for future fracture. When you see the statistic that 50% of all patients who have fractured a hip have already suffered a previous fracture. So as Paul Mitchell, who helped us on the Fracture Prevention Central resources, likes to say, fracture begets fracture. So we know that those folks are kind of at the top of the risk for folks that are going to most likely fracture again. And, you know, we hear these tragic stories of folks that have had 5, 6, 7 fractures, and in each case they've had a cast slapped on them and sent home instead of getting screened and or treated if appropriate. So really we're working very hard to try to change that paradigm. And then I would say, too, there's a general lack of awareness about the model of care itself, the FLS model of care, particularly among PCPs and hospital administrators. So I would say through efforts of a lot of these groups, I think within the bone health community, there's an awareness of the FLS model of care. But I would say the thing that we were hearing was that even though folks knew what this model of care was, they didn't really know how to get started. So really that was the whole reason that we launched Fracture Prevention Central, was to give a place for folks to get started. It was great that we were able to get buy-in and help from all of the international and national programs to share their tools in the hope, and expertise, of course, in the hope that we could continue to help other folks do the same, and folks aren't having to reinvent the wheel, but they can have some good starting points to move their own forward. And as I said, this is just, once again, emphasizing that we need to come up with another 850 programs to get to our 2020 vision. And I would say, just anecdotally, since we launched Fracture Prevention Central 2 months ago, we've been in contact probably with 30 to 40 groups that don't have existing FLSs that are looking to implement. So we're very pleased to see that Fracture Prevention Central is already starting to light a fire under folks to get this done. So now I just want to take you through a little delay here. Just kind of at a high level, what tools are available on Fracture Prevention Central, and then once I run through that, I'll turn it over to Rick, and certainly maybe after my talk we can do some Q&A if there are some folks that have questions to ask. So certainly feel free to queue up some questions if they've come up already. So as I said, we launched about 2 months ago. We compiled materials from a number of domestic and international programs, and really our goal is to enable interested sites to start implementing an FLS, and really to also provide a virtual place to share best practices, experience, and tools. We'd love to also be able to, at some point, and you can see, if you see the icon that says Find a Site in the website, would love to be able to have a national map that shows all of the programs, because I think the other thing that, the other opportunity we have is for sites in the same or similar geographic areas to work together. So really hoping that as we move this forward that we'll be able to facilitate that as well. So this, just at a high level, is the major kind of pieces to Fracture Prevention Central. So first, kind of overview on the prevalence impact in the impact of fracture section, what we like to call Fracture Liaison Service 101. Really, what is an FLS? What current programs exist? What the role of various health system stakeholders are. And then we have a variety of FLS tools up. As I said, kind of the where to start, what the first steps are in establishing an FLS. Some reimbursement guidance, which actually we'll have some more detailed information up in the probably next week or two related to reimbursement. Some sample business plans, because obviously the first thing you'll need to do once you pull together the stakeholders is to make the case to hospital administration why you should do this and how it will be cost effective and certainly help improve adherence to the various quality measures. We also have a number of case studies from the other successful programs up, and quality improvement tools. And then also just specific resources from all the groups that have been moving this model of care forward. And then, as I said before, a kind of mechanism to find a site which isn't populated yet and which we'd love to be able to populate. So this next slide just shows kind of the site map and kind of what the major pieces are on Fracture Prevention Central that we hope is helpful as you look to navigate the website. And certainly would also love to get feedback from folks on other tools that you would like to see. We're constantly wanting to continue to refine our tools, to develop new tools that would be helpful for folks to have. Really we're here to support everyone's effort here. And then the next couple slides just are kind of quick links to kind of the top 10 pages on the site for folks that are just getting started, because we know we have a number of pretty large number of pages here, and just to be able to help folks navigate a little bit easier. And I guess the other thing to say is that this slide deck, as well as some other materials, are available under the if you look at the tab that has attachments, you can get the slides, you can get some more information about MDHA, et cetera. And then the other thing that we're doing, in addition to Fracture Prevention Central, is sponsoring this 6-part series, the first one being today. We'll be rolling out additional topics and programs over the next few months. The goal is to have one every month, except for I think we're going to skip August, pretty much through the end of the year. So you see here the major titles and kind of focus areas of the other talks that we'll have. But certainly if you have any other topics you'd like us to cover, would love to get that feedback from you. And there actually will be, after the webinar, there will be a mechanism to provide us some feedback in that regard. So really looking forward to getting some other feedback from folks on that. And then I guess the last thing just to mention, this is my last slide, is that in terms of how we're communicating and disseminating information about Fracture Prevention Central, we'll be at a number of national specialty primary care and allied healthcare professional conferences. The first one, or at least the next one, being next week at the American Academy of Physician Assistants annual meeting here in D.C. So for folks that are attending, we'll be at booth number 641. So we'll be talking about both Fracture Prevention Central. We'll actually be able to demonstrate it to folks, as well as talk about 2 Million Too Many and some of our other initiatives. We'll also be highlighting materials from a number of our members, which is a great kind of side benefit, is to be a member, to be able for us to get that out to other folks. We continue to talk to other organizations, both on the bone health side as well as other healthcare professional groups to help spread the word about Fracture Prevention Central. We're also reaching out to accountable care organizations and Medicare Advantage plans not performing well on that osteoporosis post-fracture quality measure. So that's the HEDIS measure. Women age 67 plus who have fractured, who within 6 months have gotten either a bone density scan and or put on a medication. So that's Rick will talk about this. So about 23% is the national average right now, and obviously we want to get that up to probably 80, 90%, which is where the Kaiser program is right now. So that's a central piece in terms of folks that we're communicating with that should be very motivated to want to start an FLS program. And then also just for folks on the phone and that might listen to this after the fact, any help that you can provide in publicizing the availability of Fracture Prevention Central would be greatly appreciated. And I guess the other thing to mention is we also will be at the ASBMR annual meeting, which is in early October in Baltimore. So that's the other one that we definitely will be at. And on the consumer side, we'll also have our 2 Million Too Many Cass Mountain at the AARP 50+ meeting, which will be in Atlanta in early October as well. So trying to get out there and trying to spread the word as best we can. So with that, that's the end of my comments. I don't know if there's any questions that are queued up, or if folks would like to ask a live question about MBHA, Fracture Prevention Central, anything else that I've covered here.
Thank you, David. I will just let the audience know how they can ask a question live. If you are dialed in on the telephone and you'd like to ask a question live, press *1 on your telephone keypad. If your phone is on mute, please be sure to unmute it when it is your turn to ask a question. If your question is answered before your turn and you no longer wish to ask it, then you can press *1 again, and you'll be removed from the question queue. You can also ask a question via the web presentation by selecting the Q&A chat pod located in the lower left-hand corner of your screen. Type your question in the available box and press the blue Send Submit button. We do have a question on the line from Karen in Dallas, Texas. You may begin speaking when you hear your line has been unmuted.
Good afternoon, and thank you for the wonderful presentation. In your work with patients with fractures, I would encourage you to really ask another question when you're doing your assessment of patients with fractures, and that is, are you a DES-exposed individual? I am a DES daughter. Recent research from Retha Newbold from NIEHS has shown those exposed to the drug diethylstilbestrol in utero have indicates in the mouse model brittle bones. And I personally am experiencing that, and now I have my 4th fractures of my right ribs along with multiple other fractures. And I have not heard any dialogue from the osteoporosis group on the effects of DES and their offspring, over 10 million Americans were exposed to DES in utero, as well as millions around the world. So could you speak to that, and if this could be added to your questionnaires with intake for new patients?
Yeah, thanks for flagging that. And actually, if you could send some of the literature around that to me directly, that would be great. Actually, the last slide that we'll show at the end of the webinar has my direct contact information, but it's david.lee@mbha.org. Would love to get that information and to see how we could incorporate that.
I will be happy to send that to you, and there are 2 articles I will be sending you.
Great.
Thank you for taking my question.
Great. Any other live questions? I've got a few others queued up electronically if there aren't any other live questions.
We don't have any calls on the line at the moment.
Okay, so there was a question about other meetings we may be at. So we will be at ASBMR in October in Baltimore. Also a question about the APTA CSM Las Vegas next February. We will definitely take a look at that one because I think that's certainly another good meeting for us to be at on the allied healthcare professionals. About FLSs in their area. I guess the best way would probably be for us, because most of the active programs, especially in the open system, are Own the Bone sites. We can connect you directly with folks at Own the Bone. So Sarah Murphy is the program manager for Own the Bone. I could get folks directly in touch with her, and maybe what we can do as a follow-up, we can distribute that contact information directly to find out what Own the Bone sites may be in your local community. And certainly, as I said, as we hope to get more and more folks to register their FLS through Fracture Prevention Central as well, we'd love to have a national map that we can share with folks. So that's another mechanism that we would like to move forward. And then let's see. So next question, have we determined specific outcome measures to measure the success of an FLS program? And actually, we have laid those out, and they are part of the resources, I know, actually in the business case. So if people want to take a look at those, but as I recall, there's about 12 specific outcome measures, outcome/process measures, actually, that you can look at. If folks aren't able to see that in the business case, please let me know.
Right, and I'll cover some of those process and outcomes measures.
And then the next question was whether there was someone at Johns Hopkins that may be doing this work. And actually, I know that, so I guess the other thing I didn't mention is that about a year ago, NBHA, the National Osteoporosis Foundation, and the American Orthopedic Association pursued funding through the CMS Innovation Center. We had hoped to get funding for an 80-site pilot of the Fracture Liaison Service Model of Care. Unfortunately, we weren't funded. It was very competitive. But the good news was that because the idea was that we were to start up so quickly, we actually went out with a kind of call for interested sites, and we got 192 sites that expressed interest in participating. And we had anticipated probably having about 80 of those sites that would have been active sites funded through the CMS funds. But I know just off the top of my head that there was a group at Johns Hopkins that was among the 192. So if you want to connect with me directly, I could connect you up with the folks at Hopkins.
Okay, and we do have Karen from Dallas back on the line with a question. Karen, you may begin speaking when your line has been unmuted.
Thank you. I do have a question, and you talked about your 12 outcome measures, and I am a former member of the National Quality Forum, and are your measures going to be submitted to the National Quality Forum for review and approval?
Actually, it's great that you mentioned that, because one of the other things, which we haven't put up yet, but we should be able to communicate very, very soon, is that through an effort of the National Osteoporosis Foundation, four new quality measures were tested by the Joint Commission, and 2 of those 4 measures actually specifically call out Fracture Liaison Service, referral to an FLS, and we anticipate that getting in front of the NQF for them to endorse this fall. And if all goes well and we go through that approval process and get a high sign, actually those would become a new set of potential core measures that hospitals could use in their Joint Commission reaccreditation. So really pleased, as these additional quality measures and incentives for folks to do this work continue to line up, that's a very central piece.
Thank you.
And let's see, maybe what I should do, because I know we're about halfway through, maybe I should turn it over to Rick, because I've got a few other questions queued up, and certainly happy to connect with folks directly if they have specific questions, especially about whether there are specific sites or locations that are doing FLS work. So with that, maybe I will let me just introduce Rick, who, for folks that have met him in person, is an active nature. Really very, the person that I've worked with very closely for 2 years on this, and has really been such an enthusiastic supporter of this model of care. And I can just say we'll do whatever it takes to make this happen. So we're good partners in crime together, along with all the other folks that we're working with on this. So Rick is the lead orthopedic surgeon of the Healthy Bones program at Kaiser Permanente. And, really, not that I want to, say that he's old, but he's one of the granddaddies of the FLS model of care here in the States, and, just very enthusiastic. You're going to learn a ton from Rick on how to do this, and, he's going to make it sound simple, and it actually, at its core, is simple. But Rick is really the guy that is driving a lot of our work, as well as really helping a number of sites facilitate their own FLS programs. So with that, I will turn it over to Dr. Rick Dell. Thanks so much.
Okay, so let's start about the Fracture Liaison Service Model Care, how to actually make it happen, okay? Just knowing about models of care isn't enough. You got to adopt, adapt, or steal any great ideas from any other people and make that happen in your program. So I'm going to show you how to do that. So if anybody knows me, you know that I'm an orthopedic surgeon for many, many years now at Kaiser. We started the Healthy Bones program way back in 1998. Back when it first started, it was called the Hip at Risk program, focusing mainly on the prevention of hip fractures. And in Kaiser, branding is everything, so eventually when it went up to a national level, we had to change our name to make it sound better, and Healthy Bones actually is what we're really talking about, keeping your bones healthy, and that is what actually prevents the fractures. If you also know me, you know I love computers and information technology, and I am willing to share how you can use information technology to actually make this happen. So, I have no disclosures. So the objectives of this part of the presentation is to tell you what is a FLS program or Fracture Liaison program, and how do I start my FLS program at my hospital. So again, Kaiser, it's Healthy Bones. For the rest of the world, it's Fracture Liaison Service. So you can call it whatever you want. A Fracture Liaison Service by any other name is the same. So you have to know there's a reason why you got to get this going in the United States. And the major reason, there's an elephant in the room. Only 23% of patients who have a fragility fracture, that's a osteoporosis-related fracture, receive osteoporosis screening and or treatment. That's an 80% care gap. There's very few diseases out there that have an 80% care gap, but osteoporosis and fracture prevention is one of those major problems in the United States today. And if everybody knows we're an aging population, it'll be 75 million new baby boomers going on to Medicare in the next 15 to 20 years. And those baby boomers are going to have a higher and higher number of patients presenting with fractures. So our goal is to help prevent those fractures by closing the care gaps. The problem is we know what to do. We have we have the idea. We just don't systematically put it into place. So we have to put the system in place and do the right thing at the right time and all the time. So I'm going to walk you through a step-by-step guide to implementing a fracture liaison service model of care. So what your program needs several things. The first thing it needs are champion or champions. When I started the program here at Kaiser, it was just at my medical center. It was me as the champion and my secretary as the worker. She would be doing all the calls, scheduling all the DEXs, making sure the follow-up was done. The initial startup cost at Kaiser was $0. I did this during my lunch period, and my secretary did this during the lunch period. I guess it's not $0 because I actually would pay for lunch for both of us. But your startup cost can be extremely small. The champion then has to expand his program, bringing in more and more team members. And this is from an interdisciplinary team, internal medicine people, an endocrinologist, and a rheumatologist, and radiologist. Once you get your team together, you have to set a goal. And I can't overemphasize how important having a goal is. At Kaiser, our goal was very simple. We were going to reduce the hip fracture rate by 20%. And we gave ourselves a 5-year timeline to do this. We actually achieved it within 3 years. And so a 20% reduction in hip fractures forces you to think, how am I going to reduce our hip fracture rate by 20%? So what you have to do is target those people who are going to fracture. And the highest of all risk are those people who already had a fracture. David said it beautifully, fractures beget fractures. So if you look at the population who already had a fracture, those are the people who are most likely to go on to have a hip fracture down the line. So once you set your goal down, you can put your plans into place. Okay, what are we going to do? We know who had a fracture. We have our records that we sent for billing. Let's take that record list or take our electronic medical record, whatever format we have, we're going to start ordering DEXA scans on those people or initiating osteoporosis treatment on those people, get them into fall reduction programs, have them seen by our care managers. That's the plan. You start with the highest risk patients first. What you don't want to do is start with people who are 40 years old who aren't going to fracture for 40 years. You're not going to see a big reduction in hip fractures if that's the type of plan you choose. You want to reduce your hip fracture rate and other fractures if your goal is to reduce the hip fracture rate by 20%. You also have to be willing to shamelessly steal from others. So, here's a famous quote from that's a famous quote from Steve Jobs. Steve Jobs, as you know, is considered one of the greatest innovators of our time, but he shamelessly stole many of the ideas from Xerox PARC and others to act. But what Steve Jobs was able to do was take those brilliant ideas from others and actually implement them and make them better. That's what you guys can do. You can take the brilliant ideas from Kaiser and Geisinger and from the fracture liaison services in Ontario and Glasgow. Take their ideas, make them fit, and adapt and adopt those ideas to your program. If you want to see what Kaiser has done for their program, you can check out the International Osteoporosis article that lays out in detail, step by step, all the plans that we use to achieve our great results at Kaiser. So it's going to walk you through step by step what it takes. So it's called, if you look up online, Fracture Prevention in Kaiser Permanente, Southern California, by me. So it's really simple article. You can also look online for the American Society of Bone Mineral Research Task Force on Secondary Fracture Prevention. This is basically an article that lays out in detail all the fracture liaison service models of care throughout the world, what made their programs work. It also lays out programs that failed, because you should know what fails also. And so there are some very consistent things that people have done that failed, and some very consistent things that people have done that have been successful. Successful programs start with the big bang for the buck. Those are people who are going to have a fracture in the next 5 years. You then use that money you save and the experience from attacking that project to address people who have not had a fracture but are at risk for fractures. So, and this article lays that out in nice detail. So if you need to get your list of patients to identify those people who are at risk for fractures, some folks are lucky, like at Kaiser, we have our electronic medical record that will go over all the patients who had a prior fracture. You also have your billing list that you send out to get payment. There's your patients who have fractures. And there's also the list of Medicare patients that have fractures. So you have all these lists available for you to identify your at-risk population. And you need to risk stratify your patients based on the age, the sex, the race, the prior fracture. And what that really sounds like is basically a FRAX tool. So FRAX tool is something that we use here at Kaiser extensively. Every single person who comes in for a DEXA scan or is having a DEXA screening will run the FRAX on to assess what their risk for fracture is, and we use this to initiate treatment and also to determine, how aggressively we're going to target our population. So again, starting with the big bang for the buck patients, those people are most likely to fracture. And again, you work from the top down. You pick on those people who already had a hip fracture, because of all the groups of people who had a hip fracture already are most likely to have a second hip fracture on the other leg. Those people who had non-hip fragility fractures, they're the second group to attack. And then go for people who are at high risk but haven't fractured yet. Then finally get to your older patients. Again, get the list in the hands of the care managers who work the list at the right time with the right data, and you start from the highest risk and you work your way down. David said this is simple. It really is simple, okay? You work with the highest risk first. So this is an old example of an old report that we used to send out to our care managers once a month. It listed what risk group you're in and who the primary care doctor, and I redacted all the PHI information, but it gave our care managers all the information about that person. So each person in this list would be systematically reviewed, and then actions would be taken. Now, that was once a month. What we did at Kaiser now is we have a program in effect that's updated every single day. So you can see all the different categories. And there was a question earlier about the process measures that we use. So one of the process measures we use is a HEDIS measure. So a HEDIS measure says if you had a fragility fracture in a woman over the age of 67, did you get a DEXA and did you initiate treatment? National average is around 23%. Kaiser's average is approaching 90%. So we are doing a bang-up job in getting getting things done on the right person at the right time, especially when they had a fragility fracture. Also, all your hip fractures that don't fall into the HEDIS measure, like all the men fall into this category, or women who are under the age of 67, or women who are already on treatment and then stop their treatment. So you can fall into all these different buckets for osteoporosis screening. So we don't just deal with those people who already had a fracture. We also have expanded our program to the older patient. So we've walked through that pyramid, and so we started with hip fractures, moved to those people who had a fracture, and now we're to all people at risk. So again, the process measures and the outcome measures are included in this list. So the updated list has the same things that you see on the monthly report. The only difference, this is an interactive program where our care managers can click on revised data, put in what they did for the patient. They can take people off this list. They can change the parameters. They can move people from one medical center to another if the patient happens to move from one region to another in the Kaiser area. So all the data at all the time for all the patients at risk. That's our goal. And so measure how everybody is doing and looking for variation was the factor that we found that was most important in decreasing the variation from one medical center to the other. When we first started the program, we had some medical centers that were already at the 80 to 90% level on post-fracture care, and we had other medical centers that were in the 20% range. That huge variation is unacceptable. And that's what we see in the United States at this time. There is a huge variation between medical centers that have below a 20% post-fracture management rate and others that are at 90% post-fracture management rate. That is unacceptable, and Cyrus, who she was right here, she would say that's bad medicine. So that's unacceptable to have that much variation when it comes to patients who have fractures or at risk for fracture. So we look for our variation at Kaiser. We look for not just from region to region, from medical center to medical center, but we also look for age group to age group. So we look at men and women, and you can see that women overall tend to get DEXA scans and tend to get the treatment more aggressively than men. We also men tend to deny the fact that they even have osteoporosis. It's really tough to get a guy under the age of 70 to even admit that they have osteoporosis. As you can see, 90% overall for DEXA screening and treatment after a person had a fragility fracture. So pretty good work for Kaiser. And if you look for the expected and actual number of hip fractures and broken down by all the age groups, all health plans use actuarial tables to predict how many hip fractures they're expecting and how many heart attacks and strokes and all those bad outcomes. So our senior leadership knows how many hip fractures to be expected and what percentage of population should have a hip fracture. And you can see across the board it's over 40% reduction in our expected rate of hip fractures for Kaiser. So that's one of the outcome measures that we aggressively monitor to make sure our program is doing well. And so once you've hit your goal, what you need to do is reset your goal to a higher level. And when we first started our program, our goal was 20% reduction in hip fracture rate, and we passed through that very, very quickly. So remember, this is a journey of constant improvement for your Healthy Bones program. So keep resetting your goals. Keep resetting, how you're going to reach that goal. Constantly looking for other programs that have ways to do the job better. Now, that's what David, Lee, and I are going to do for you. So initially, again, our goal was to reduce the hip fracture rate by 20%. That was back in 2003. We achieved that very quickly. In 2007, we said, let's do 40%. We've more than achieved that. And now we're at the goal of let's reduce our hip fracture rate by 50%. And as people on the call are probably aware, that's about the limit as far as just pain medication. As far as anti-osteoporosis medication is going to get you. So you're not going to get to 100% reduction in your expected hip fractures, but you will get to 50% if you get all the folks on medication and keep them on medication, and you may do better if you get them into fall prevention programs and all the other factors that lead to reduction in hip fractures. So to do this, what you need to do, and you can basically take this from Kaiser, it is on the fracture prevention website. Here's our clinical practice guideline for osteoporosis and fracture prevention. It's yours. So if you go to the website, it's there for you. You don't need to spend hundreds of hours developing a clinical practice guideline. You basically can take it from Kaiser. The clinical practice guideline, though, is useless if your team doesn't use this. So you've got to have your clinical practice guideline used by the team. And it has to be systematically used by your team. You can't just, you just can't turn it over to a bunch of primary care doctors and say, here's the guideline, use this. That doesn't work. You have to have your team help coordinate the patient's care and systematically use the guideline. And that is what we really mean by a fracture liaison service model of care. It's taking the guideline, putting it into an information technology system that generates the list for your care managers to use each and every day. That's how you get to a 90% care, 90% of your patients getting the proper care. Because, basically at Kaiser and other places, we found that success equals the right people, the right processes, the right steps and actions to take, the right people to target, and the technology in place. So we're lucky to have an electronic medical record. Other people have an electronic billing record. So no matter what you have in place, you can build your team. You can build the steps that are going to be used to address the at-risk group, and you can use the technology available to you to help with that job. So that leads to success. So in this slide I love, we as physicians and practitioners, our job has really changed. There used to be what's called the industrial age model of care, and I kind of equate that to Marcus Welby. He saw one patient at a time. The patient had to be right in front of him to be taken care of, or he would make his home visit. He had no use of information technology, and he had very, very limited use of extenders. The information age has a different model of care. It uses accountability for your panel and population. You are accountable for every single person in Kaiser who has a care gap. It's transparent. Everybody sees who has that care gap. We use our electronic medical record, registries, and our intranet-based application to basically push out to our care managers the list of patients that need this done. A team of patients involved in the patient care, not just the single primary care doctor. And we move the care out of the doctor's office. We use virtual visits as much as we can to do this care. So we still have face-to-face visits, but as much as we can do virtually, we can. And so here, we're enabled by the information technology and performance measures. At Kaiser, again, we have a fully functional electronic medical record. We call it Health Connect. Our patients see their version of Health Connect on what's called the My Health Manager, and frequently use performance and outcome measures for constant quality improvement and accountability. So we constantly are measuring how well we do. And so when I say it takes a team, it takes a great team. And this is my team in Kaiser, Southern California. And I'm extremely proud of the great work that my team does. And I always tell people, my team does the work and I take all the credit. And they understand that. I'm the guy who actually publishes a lot of the work, but these are the guys and girls who are actually doing all the work. So that is my team. And, great kudos for my team. And you should always hold your team in high esteem. If you want to read more about this, you can go online to the AHRQ website, look up Healthy Bones on their website. It's easier if you just go to Google and type in Healthy Bones AHRQ Innovation. You'll see our website's number one on that list. Also, as David pointed out, the National Bone Health Alliance has the case study in it. It gives us our policy and procedure manual, our clinical practice guideline, our model of care, our business case. Everything is there. The Fracture Prevention Central is an excellent resource, and you guys should be using this resource. Don't start from scratch. Take what others have done. Adapt and adopt what others have done and make it your own. This is the one time in your life that plagiarism or blatant stealing is totally acceptable. In fact, that's the best form of flattery, is to take what I've done at Kaiser and to make it your own, okay? Finally, I'm going to open up with questions with another 5 minutes to go.
Okay, thank you, and I'll just remind the audience to ask a question live on the phone. Press *1 on your telephone keypad, and just be sure to unmute your phone when you're selected to ask your question. And again, to ask a question via the web presentation, select the Q&A chat pod located in the lower left-hand corner of your screen. And we do have a call on the line from Karen in Dallas, Texas. Karen, you may begin speaking when you hear your line has been unmuted.
Thank you. Dr. Dell, this was an excellent presentation, and I thank you for being at the forefront of this and putting it forward with AHRQ. And you're so right. Learning from lessons learned and best practices from others is the best thing to do in the healthcare delivery system. I would also like to commend Kaiser for having the EPIC medical record system. I think it's an excellent system to help track your patients. So again, thank you for all the work that you do, and I'll be sending you your email shortly.
Thank you. You know, in this era of big data, what people forget is, you know, they get scared by big data and they don't understand how they can use it. Big data, when converted to what we call mini registries, and a mini registry is a very disease-focused area where there's care gaps. So that's what the Healthy Bones program has done for our registry. We have taken all the care gaps related to osteoporosis and fractures and draw from that data warehouse, add all the rules for what makes a care gap, and then make that registry available to our care managers. So I'm willing to help anybody who has an electronic medical record or a billing record to convert big data to these mini registries. And Kaiser, when I say mini registry, not too many people have a registry of over 1.3 million patients and call it a mini registry. I think that's just kind of unique to Kaiser, because we have 10 million patients or coming up to 10 million patients. We're at 9 million plus, but we soon will have 10 million patients. But each of our regions will break it down into their registry. So for Southern California, the 1.3 million people who have some at-risk factors for osteoporosis and fractures, that's what we have done for our registry. So I'm going to turn it back over to David.
Great. Thanks so much. And I guess just one thing to mention, Rick, I know you're in control of the presentation. Can you just forward?
I just gave you control.
Oh, great. I just wanted to give folks, both myself and Dr. Dell's direct contact information, if I can do this right. Here we go. Yeah, so just to make sure that everyone has it. So I can be reached at david.lee@mbha.org, and you see Rick's email address as well, richard.m.dell@kp.org. And then also you can see the connection to Fracture Prevention Central. So just the last plug, for those folks that haven't registered, and it's a very short 20-second registration process, please feel free to do that. Everything that you'll be able to access is available at no cost, but we just want to be able to connect with folks that are using the resource because, as I said, we want to make this virtual community of folks, now that we have over 500 so far that have registered for access, want to continue to increase that number and to help folks implement their own FLS program, and certainly for folks that have already started on the road, be able to address issues, concerns, questions that they're getting from their institution as they move forward.
And David Lee and I have been very available for conference calls. If you want to set up a conference call with your team or if just you, we're more than willing to set up time to go over exactly how to implement your business plan to try to set up an FLS at your health plan.
Thanks.
And we do have other members from the Kaiser Healthy Bones program who are more than willing to help out also. For those who were at the National Osteoporosis Foundation meeting, we had an excellent presentation from our folks down from Kaiser San Diego, and they're more than willing to share their day-to-day experiences with you, what they actually do to make this program work.
Thanks, Rick. And I guess just the other thing to mention is that this will be archived and should be available next week. So for folks that weren't able to participate live, still have the ability to experience the webinar, get the materials, as well as you'll be able to access those attachments that we provided. And one of the questions that came through was the question whether we could provide that in PowerPoint version, and so we'll be sure to upload a different version for folks that may want to use a couple of the slides that we presented today, because I think that's always helpful. And actually there is, as part of the business case tool deck, there's not only a Microsoft Word version, but also actually a generic PowerPoint slide version. So even as you have to go in and give that presentation to hospital administration, you'll have the ability to have some slides to really serve as a first step to pull that together.
Yeah.
So I see we're at time. I don't know, are there any last live questions? And we'll do our best. I know I can see a number of other electronic questions we've gotten that unfortunately we're not going to be able to get to. But certainly if you have specific questions, follow up with Rick and myself.
Please email us. This conference call doesn't end now. This is just the beginning, guys. We have 5 more of these WebEx presentations, and we have hundreds more meetings with folks who are interested in starting up a fracture liaison service. So don't think, oh, I didn't get my question answered. You will get your question answered. You will get your fracture liaison service up and running, and we will hit the 2020 vision. I am determined to reduce the hip fracture rate by 20% by the year 2020. Whatever it's going to take, I'm going to make sure it happens.
Okay, thank you, David. Thank you, Rick. On behalf of the National Bone Health Alliance, we thank each of you for participating today in today's program. This concludes an introduction to Fracture Prevention Central, the fracture liaison service model of post-fracture care coordination. Please be sure to complete the evaluation by following the link, which will display on your screen momentarily. Thank you again for joining us, and have a great day.